My name's Ron Wapner. I'm in the OBGYN department, head of reproductive genetics. And what we're going to talk about today is personalized medicine for the fetus. And I know people don't really think about prenatal period as a period where you can have diagnoses and that you can do treatments, but hopefully I'll point out to you that there's a lot of important information that makes a lot of difference when we talk about fetal care. The whole issue of doing genetic diagnoses on a fetus started over half a century ago. And that was when the observation was made that as a woman gets older, her chances of having a child with a chromosome abnormality, and in particular, a child with Down syndrome, significantly increases. So you can see that a 20-year-old has about a 1 in 1660 risk of a child with Down syndrome. And by the time that same woman is 32, her risk is actually doubled. And then a woman at 35 has doubled again from a 32-year-old woman. Now, what you're saying is, no, didn't I hear that we worry about advanced maternal age for women that were 35 years of age and older? And indeed, that's true, because the slope of this increased risk of having a child with a chromosome abnormality increases much more dramatically over the age of 35. But this really was the first screening approach for diagnosing fetuses with abnormalities. The screening test was easy. Mrs. Smith, how old are you? And if she said she was over 35, she was screened positive, and then she was offered additional evaluation. And if she said she was under 35, she was risk or screen negative. Whenever one is doing screening, you have to make arbitrary decisions. And one of the decisions that had to be made was, how old does a woman have to be in order to be considered high enough risk that you will go from the screening test to the diagnostic test? And so then there was a big meeting at NIH and NICHD, and they looked at a number of factors. They looked at the increased risk that I showed you. They looked at how many places had available invasive testing by amniocentesis. At the time of this meeting, there were 5 or 6. Things were relatively new at that time. And then based on that and the costs and the number of people that knew how to do amnios, they made a relatively arbitrary decision based predominantly on logistical concerns, not because, as I showed you, there was any biologic dramatic risk from 35 or older, that any woman that was 35 or older was offered invasive testing. At that time, that risk would be about 1 in 270. That's the risk of a 35-year-old having a child with trisomy 21. So that was the risk threshold. The population at risk at that time, your screen positive patients, because don't forget, to be screen positive, all you had to be was over the age of 35. It was only 5% of the population. And the detection rate, the number of affected pregnancies that were in that 35 and older population was only 30%. And every woman over 35, her odds of having a Down syndrome child was 1 in 100. This was a horrible screening test. Basically, it had a 5% false positive rate, and we only identified 30%, because even though that was a population at the highest risk, the vast majority of your population was having children, were under 35, so we really weren't able to diagnose it in most of the people that actually had affected pregnancies. If today we did the same thing, it would really be different, because now almost 15 to 20% of pregnancies are occurring in women over the age of 35. So our false positive rate, or our screen positive rate, really would be about 15%. And because more women were in that older age group, we would diagnose about half of the affected pregnancies. Despite the fact that this was really not a great screening performance. It persisted for another half century. And as recently as about 4 or 5 years ago, that was what we were doing. Well, maybe 10 years ago. That's how we were screening pregnancies to see whether or not the fetus had a genetic disorder. So I just present this to give you the perspective of how things have changed so dramatically and so radically in the past 5 years. At that time, we also were naive and arrogant. This is an article from Lancet in 1977 called Who's for Amniocentesis? The procedure had been done maybe 6 or 7 years, and they opined that virtually all chromosomal aberrations can be detected by amniocentesis. We thought that now that we could look at chromosomes under the microscope, we knew all genetic disease. So we know that now that that's not entirely true. But even then, this is what chromosomes looked like at that time. Most labs doing prenatal testing weren't even banding the chromosomes. So we separated by them. The biggest ones were number 1, the next biggest were number 2, and we used to sit around in the lab arguing which was smaller and which ones were 21s and which ones were 22. But that was the state of the art when we, and Lancet's a really superior journal, had the audacity to say that we could now identify all chromosomal aberrations by amnio at prenatal diagnosis. Since that time, the ability to look at metaphase chromosomes has dramatically increased. Here are those old blobs, unbanded chromosomes, and as you can see, there's 3 number 21s, trisomy 21 Down syndrome pregnancy. But we began to band them so we really could differentiate different portions of the chromosome. So while when chromosomes looked like this, we could just tell whether there were too many or too few and maybe some very large translocations, as we began to band them, we could now identify inversions, very small translocations, deletions, and everything, and many things that were much smaller. However, the limitation of this technology is you have to look at it under the microscope. And no matter how we tried to band them, the limiting factor was you could just only see things to a certain resolution. Well, in the last 10 years, we've gone from chromosome analysis by looking at karyotypes to molecular karyotyping. And the tool that has done this is Chromosomal Microarray. And I'll take a second to explain it, although I would assume many of you are familiar with it. And what one does with Chromosomal Microarray, you basically take all the chromosomes, and this is just a cartoon illustrating it. The chromosomes can then be broken up by a number of means into smaller pieces. Those smaller pieces are then put onto chips. We then take a sample from the patient, we hybridize it to these chips, and we ask the question of is there missing or overrepresented DNA segments, small segments in the patient, because that would tell us whether or not they hybridize to this area. So after one hybridizes them, this is what one sees. There's fluorescent probes on these, so that, the yellow are the ones that are normal, euploid, but deletions in which a small piece of DNA is missing would be in red, and in green would be areas of duplication. So this is not read by a human any longer. This is obviously read by a computer, and we don't any longer, although originally we used to physically chop up the chromosomes, but we actually know the sequences from the Human Genome Project from almost any location. So all we got to do is say to the computer, right here, knowing that, say, chromosome 1, P arm, whatever we want, has this sequence. Say, okay, put CATCTG, etc., and then we move to the next one and the next one so that we can actually put portions of any portion of the genome that we would like. So nowadays, we don't do, in most cases, karyotyping. We use chromosomal microarray, and this is what a karyotype looks like today. These are all the probes for chromosome 1. These are the probes for chromosome 2, chromosome 3. And any areas that are either deleted or duplicated would be represented by a deviation of the color from the normal area. So the only limitation now to how well we can view the karyotypes, how many probes we can put on a chip. When we first started doing this 7 years ago, we used 44,000. Now you can put about 2 million probes on a chip. And if you really wanted to, you could even do more. So like I say, we're only limited by how many pieces of DNA we can put there. So what does this mean? Well, we've now gone from banding, and the resolution with banding was 7 to 10 million base pairs. In other words, any deletion or duplication smaller, and with prenatal testing it was closer to 10 million base pairs, smaller than 10 million base pairs would not be, you wouldn't be able to identify it. As I said, with arrays nowadays, we're only limited by how many probes, so routinely we can see things that are 500,000 or 500 kb, 500,000 base pairs, and by using high-resolution probes, we can easily, routinely see things that are overrepresented or missing as small as 100 kb or even smaller than that. But for prenatal testing, for reasons that we'll talk about in a while, looking for a lot of little things is going to give us a lot of information we just don't know what to do with. So with prenatal testing, we kind of limit ourselves to things that are somewhere between 500,000 and 1 million base pairs. But indeed, that certainly has been a gigantic technical improvement. But for all of us that practice clinical medicine also, the question is, it's great technology, it's really neat. The labs have rushed into our offices. You got to use this, you got to use this. But what we next had to find out was, does it matter that we can see these small things? So with time, the answer turned out to be absolutely positively yes. We realized that there are things called microdeletion syndromes, missing small pieces, and by syndromes, that's an association of findings that you see together all the time. So that many of these microdeletion syndromes, which weren't known about a decade ago, are now very, very well known. One is Dosage syndrome, where you're missing a piece of the long arm of chromosome 22. This is the most common microdeletion syndrome. But look, it's only 3.5 million base pairs, totally unable to be seen by karyotyping. There's Miller-Dieker syndrome, which has severe lissencephaly and a severe brain malformation with developmental delay, well and significantly worse than Down syndrome or some of the whole chromosome aneuploidies, and it's only about 1 to 3 million base pairs. Prader-Willi, that many of you have heard about, Smith-Magenis, again, very, very severe syndrome. But the important point is that all of these, all the ones listed here, are way too small that they would have been seen by normal karyotyping. We've also learned, which probably is equally important, is there are non-syndromal effects by a small deletion or duplication. And by that I mean it doesn't have physical findings, there's not a lot of things that go with it, but for instance, if you're missing a small piece of the short arm of chromosome number 16, and that's only about 550,000 base pairs, there's a strong association with autism. And that's one of the causes that we now have known for sure is genetic causes of autism. If you're missing a piece of a slightly larger but still less than 1 million base pairs on the long arm of chromosome 1, intellectual disability, microcephaly, and again, this portion of 13 is autism, and actually things like schizophrenia have also been clearly shown to be related to these tiny little microdeletions and duplications. It's gotten to the point where the pediatric geneticists, when they see a patient, they don't even do karyotyping anymore. They go straight to microarray analysis. And the reason is a number of studies that have illustrated that if you have a child who has dysmorphic features, neurocognitive disabilities, or other or multiple congenital anomalies, and you do a karyotype, and the karyotype's completely normal, meaning you would have told this family there's no genetic cause if you just had done a karyotype. 15 to 20% of those, if you do a microarray, you will now identify a cause of that child's difficulty. So why, since microarrays can give you the same information as karyotypes, plus well more, there's no need in these children to actually do a karyotype. So the answer of, are these missing pieces important? The answer is absolutely positively. There can be very severe effects, and then there can be more subtle effects, but they're certainly well-described phenotypes. Oops. So how do we use this, and how often does this occur? Well, there have been a number of studies that have looked at fetuses that were diagnosed in utero by ultrasound as having significant structural abnormalities. All of these listed here had entirely normal karyotypes, but then they went on and had microarray, and the numbers are staggeringly consistent, which you rarely see in multiple large studies. But about 6% of the time, if you, even despite a normal karyotype, you'll have a microdeletion or duplication that's accounting for that child's structural anomalies. Now, it does vary. It varies by, if there's only a single anomaly, it's about 5% incremental value. But if there's more than one anomaly, and fetuses frequently have multiple anomalies, it's 12%. And if you look at cardiac abnormalities, it's about 15 to 20% in that group. So it varies by how many anomalies, and it varies by the specific system. But you can see that copy number variants are a significant cause of structural abnormalities that we had no idea about until the last 5 or 6 years. Let me give you an example of how this might work. Here we have a heart. Here is the right ventricle, the left ventricle. Here's a large hole between the right and the left, a ventricular septal defect. Here's an aorta, which should be coming out of the left ventricle, but as you can see, it's overriding the septum. So it's in the aorta's in the wrong place, and there's a ventricular septal defect. This is a typical tetralogy of Fetal, well known, and I can guarantee you that when we diagnose one here at Columbia, because we probably have some of the best cardiothoracic surgeons anywhere, they say, tetralogy of Fetal, I can fix that. I know how to do this. I'm the best. All of them are the best surgeons, just ask them. And I can fix it without any difficulty. And they're right. But what they're missing is some of these are not just heart abnormalities. Some of these heart abnormalities are markers for a more serious problem. And in this particular case, indeed, the only thing we saw on ultrasound was the structural tetralogy of Fetal. But then we did a microarray and realized that the cause of it was the missing 22q11 portion from there, the DeGeorge syndrome. The children with DeGeorge syndrome have a very typical facial appearance with a relatively broad upper nose. They frequently have a very small or cleft palate. They have kind of a very unusual speech because of the palatal abnormalities. But in addition to the heart defect and the facial changes, 90-some% of them have some learning disability. And of those, about 30% will have severe disabilities. So without the use of the genetic testing, we wouldn't be able to give the parents a full prognosis about what this particular heart defect was, and we would obviously be giving them incomplete information. What's even more incredible, and we'll come back to this theme again and again, one of the most significant problems with this chromosome, with this microdeletion, that was identified because of a heart defect is that as these children get to adolescence, somewhere around 1 in 4 of these children get severe schizophrenia and severe mental illness. So really, as you talk to people that take care of these children, and there are large clinics where many of them go, they'll say the most difficult part for the family isn't the heart defect, it's actually the significant behavioral and schizophrenia and severe mental problems these children have. So there's 2 points. Number one, we're now able to give parents a lot more information specifically about what to expect and what the prognosis is and what healthcare problems to plan for. But number two, who would have ever thought that a heart defect would be a marker for schizophrenia. But until we had the ability to look at the genome and start understanding that the same genetic problem causes all of these phenotypic changes, these associations weren't nearly as logical as we thought they would be. I mean, I remember when I was in medical school, you know, the only way we learned syndromes was we had to memorize 6 different odd things with no understanding about how in the heck they could be in the same person. But now we're understanding the common underlying genetic thing. But from a clinical standpoint, it's important to know this because we actually can counsel these patients much better. This is a clubfoot. Typical clubfoot. This is the radius and ulnar, the lower leg. Here's the heel, and then this is the portion of the foot. Club feet in and of themselves are common. And normally, if there's no other structural anomalies, we used to tell patients, don't worry about it. We have a way we can treat this. It doesn't look like it's one of the severe chromosome problems like trisomy 18 or trisomy 13. But, you know, we could do an amniocentesis, but, you know, maybe you don't even need one. And the reason we would say that is we knew all we were looking for with karyotypes was whole chromosome aneuploidies, and we knew this wasn't a whole chromosome aneuploidy. But in this case, the woman said, well, I'm neurotic. I really would like to have an amnio just to make sure. We did the amniocentesis, and we were correct. It was not a whole chromosome aneuploidy. The child had a normal 46XY male karyotype. But she then had an array also, and there was a 1.4 million base pair gain on the long arm of chromosome 7. As a matter of fact, this occurs enough that there is actually a 7q11.23 microduplication syndrome. So we were able to tell her that this is associated with the clubfoot, which we saw by ultrasound. But these children all have a very common facial appearance, and unfortunately, all of them have significant developmental delay. So the moral here is that things that we didn't know to start looking for a genetic cause for, as we've gotten better tools and better ability to do that, we're now realizing that many of the structural anomalies that we didn't think were really genetic in nature are genetic, and because they are, we can really give parents a much better handle on the phenotype. As a matter of fact, now any fetus we see with a structural anomaly, no matter what it is, what we think it is, we are doing invasive testing with amnio or CVS. Most of the time it's later, so it'll be amnio. As a matter of fact, and doing a microarray. 2 weeks ago, we started a study in which any fetus with a structural anomaly, we're now doing whole exome sequencing because that's being done as a research project, but we realized that this is a lot of important information and can really make a difference. So the question is, that's with fetuses that have structural anomalies. And I think most people would say, okay, that's a good place to look for genetic disease. But what about the rest of the population? Should we really start looking and offering this kind of testing to every pregnant woman? And this is from 2 studies that we've done. And here, we looked at women that were having prenatal diagnosis for the routine reasons, because the mother was over 35, because there was a positive screen measuring nucleotranslucency and biochemistry, or she just had anxiety. And lo and behold, we did karyotyping, and this is the results from the pregnancies with an entirely normal ultrasound, no risk factors whatsoever, and a normal karyotype. And in the original study, where we looked at about 3,000 patients, 1.1% of sequential pregnancies had a pathogenic copy number variant. We repeated it, and actually the numbers we now have are more than this. Altogether now we have 8,000 sequential pregnancies, and this number of about 1 in 90 pregnancies having either a microdeletion or a duplication has held up. When I first saw this, I said to myself, wait, this is ridiculous. I said, what are we doing? What's wrong with this test? But then I started to think, What's the incidence of autism? 1 in 80 or so, maybe slightly higher. The incidence of children 3 years of age that have severe developmental problems is 3%, and the incidence of children between 3 and 5 that have some either learning disorder or other developmental, not necessarily severe, is 15%. So finding 1% of the population is just beginning to unearth some of the genetic causes of some of the developmental problems that we see in children as they're growing up. So you could make a case that maybe we should test every pregnancy to look for this. Well, the counter argument, why would I want to know this? Well, one argument is some of these things are really, really bad. Like I said, some of the copy number variants, despite their size, have severe, debilitating phenotypes. And some patients might want to make a decision not to continue that pregnancy. But more importantly, what we have done, prenatal diagnosis used to be thought of as having two options. You investigate a pregnancy so that you either continue the pregnancy or it's so bad you terminate the pregnancy. No longer is that the case because we now are able to identify, again, personalize these findings so that many of the microdeletions and duplications, because we know them, alter how we take care of these children. As a matter of fact, if you know a child has a high risk for autism and you do really early intervention, that child does much better than if you wait until you get signs and symptoms. Children with learning disorders or potential learning disorders or developmental delay, early infant stimulation makes a significant difference. So from developmental issues, knowing it is important and can really begin in the fetal stage to develop a life course. Equally important, there are treatments for some of these. As a matter of fact, we now know that fetuses with Klinefelters, it's not a microdeletion, it's an extra X chromosome, it's 47X, 2 X's and a Y, that if you give them testosterone early in life, you significantly increase their IQ and neurocognitive capabilities. So that's another example. We know that there are some other disorders that are so severe at birth that if you don't get immediate treatment, and you might not if you didn't have the diagnosis, that there could really be an alteration of that child's health. This is just one example. The 22q11.2 I spoke to you about, these children, along with all the other things, have a strong tendency to getting neonatal hypocalcemia, and this hypocalcemia can be so low that they can have seizures. This study demonstrates that there's much more long-term cognitive impairment because they have hypocalcemia. Well, these children could seize within the first couple of hours after birth, long before, because you say, well, why don't we get all this genetic testing after birth? Well, you don't have time to get that results for some of these. So there's a number of other conditions that really will matter by having that information and will help us treat these kids very differently and again, improve the outcome. So really, it makes a difference and having that information can alter what we do. So nothing is ever as good as it sounds. Everything has good sides and bad sides. So are there any reasons why we wouldn't do this kind of genetic testing on every pregnancy? Well, there's two reasons that stand out. One are that we sometimes find variants of uncertain significance. In other words, we'll find a missing or overrepresented piece, and we just have no idea what the phenotype will be. We can look at the genes there, and the genes haven't been described in disease. And to tell you the truth, we're not yet anybody in the point where we can say this particular gene missing will always or absolutely lead to this phenotype. It can give us some guidance, but there will be variants of uncertain significance. And then the other thing is something that I alluded to already, but I'll talk about in a little more detail, that there's significant clinical variability called variable expressivity. So the same genetic change in two different people can have a significant different effect. Just like the 22q. It could be a heart disease in some, it could be schizophrenia in others. And how do you counsel parents based on, well, maybe it's going to be this and maybe it's going to be that? So let's just talk a little bit about these two effects. Well, first of all, variants of unknown significance are not unique to microarray technology. We've seen them forever. They're relatively common. And it just takes some time to figure it out. So what we did a study, and we had 165 copy number variants. And copy number variants is inclusive. It just means microdeletions and duplications. And we took the same group of experts, and we took what was in the literature. And between 2008 and 2011, 2.5% of these were felt to be a VU, or a variant of unknown significance. The group came back in 2012. By then, we had a knowledge base so that only 1.5%, same group of copy number variants. Last year, we did the same thing, and it's almost 1/3 or 2/3 lower. Only less than 1% of those were now variants of unknown significance. So it just points out how important it is that we keep this genetic information, and because it's really necessary to apply to people. It's not going to be any different than what we're doing with sequencing. As many of you know, there have been thousands and thousands of people sequenced, but we've just started with national endeavors so that they're going to put all the mutations into a database and put all of the phenotypes into a database, so we're not going to be guessing so much about what some of these genetic changes are. So there's really become a responsibility of labs that are doing this to submit this to the government and let them put it into an NIH database. And the same thing, I'm sure, will happen with many of the mutations that we don't understand yet that happen to the microarray findings. Although I do have to point out that the informed consent now says that I will share your genetic information with the USA government. I can tell you there are people that are not so comfortable with approving of that because the government sometimes doesn't have a good reputation for how it handles that particular information. But once you talk to them and tell them it's anonymized, et cetera, in general, most people will do that. And that's what we're doing, and that's what we're going to have to do so that we can be more informative. Talk a bit about variable expressivity, or how the same gene can look different in different people. This is a New England Journal article from 2008. And it was the association between a 16p11.2, a missing small piece microdeletion on chromosome 16, and autism. And this article goes on to say, and this is a very early article, that of all the individuals that have this, 15% will have autism. In other words, they're saying that this is a non-penetrant gene. If you have the gene, only 15% will get autism. And that's really difficult to counsel people about. But that's called non-penetrance, when you can have the gene and have no effect. Since then, however, there have been large series, this was done through the Simons VIP Autism Project, in which they've looked at many, many more kids. And it turned out that indeed, 15% did have autism. But then look here. All these other things were also associated with that 16p11.2. Mood disorders, ADHD, intellectual disabilities, et cetera, et cetera. So only 6% of individuals that have that had no phenotype whatsoever. So it's not, and it's turning out to be this way for many, many genetic mutations and deletions and duplications, that many of them are penetrant, but the expression can be so varied, we really don't realize that. I can tell you that with the 16p11.2, the one that, I'm sorry, with the 2211, the George syndrome, we frequently see kids, and then we test the parents who think they're normal, and they have the same exact thing. But then when we talk to the parents, they either have a speech problem, or they have some developmental problem, or third grade was really tough for me. They just had a variable expressivity of it, and that's what we're seeing with a number of these things, which is represented here. And sometimes this can be really subtle. These are families of children with 16p11.2 and the children themselves. The children themselves with the deletion are in red, and the other family members are in blue. And the reason we compared them to family members is the best determinant of your IQ is your parents' IQ. So we really just did the parents' IQ and the affected kids' IQ, and as you can see, all the individuals, or on average, I should say, the individuals that had the 16p11.2 deletion had a 28-point lower IQ than all the other members of their family. And you can also see that if we said, does this particular chromosome abnormality cause developmental delay or cause intellectual disability, in other words, use it as a dichotomous variable, you can see that there would be lots of people that you would say this is non-penetrant. They didn't have intellectual disability because we've made these arbitrary cutoffs. But when you look at what their potential was, you can see that this particular genetic abnormality significantly decreases the potential compared to what it would be based on these kind of factors. So we really are learning a lot about how these also cause variable expressivity. The other thing, and I alluded to this too, is this is a large number listed here of these copy number variants that we see in both prenatal testing and in adult testing. And this is the spectrum of phenotype that they have. And what's amazing is almost all of them have some finding, but it can really vary even within the particular abnormalities. For instance, as I said, the 22 Qs, you can either have intellectual disability, you can have autism, you can have schizophrenia, you can have epilepsy. If you look at this one, the 16p1311, some people will have epilepsy, some people will have schizophrenia, some will have different things. So we're really learning, and kind of we were naive when we anticipated that we would see a specific genetic abnormality and expect it to look in the same in everybody. What this genetic alteration is doing, it's altering brain development very early. And some brains, when they're developing awkwardly or abnormally, might result in epilepsy. Others, with the same change, might have other things. So again, no longer do we think of a lot of these things as being associated with one direct abnormality. It's associated with a developmental problem of an organ, which can manifest itself very differently in different people. Now, from the standpoint of prenatal counseling, this certainly can make it more difficult because parents really want more specificity. And just take a minute, because we do prenatal microarray, and I know people are afraid and always have been that when we see things like this, parents are going to say, oh my God, I'm intolerant of this, I want to terminate the pregnancy. Indeed, a small group of people do, but our experience is over 75% of individuals have said, that's important information, I will share that with my pediatrician, we will develop a plan, and I'll continue the pregnancy. That did surprise me. I did think that parents would be somewhat intolerant, but I've also learned that they understand genetics as well as anybody. We've always been afraid maybe we won't be good enough to explain these things to them, but they understand it well, and they've made some very, very wise decisions. The other thing to point out is this variable expressivity isn't new because we're using new genetic tests. It's as old as genetics. It's as old as man. Here's a family, and here's the daughter, and here's the mother. You can see, and this, I blew up the mother's face because she's got giant neurofibromas over her whole face. She's got severe neurofibromatosis. And here's her daughter, and she's not related to me, we just both have similar hair. And you can see that she does have a relatively large cafe au lait spot, which goes along with neurofibromatosis. But that's the only sign of neurofibromatosis she has. She doesn't have any of the tumors or anything else, but because of this, we know she has the disease. Well, she comes and says, I want to have a baby. Am I going to have a baby like me, or am I going to have a baby like my mother, who's going to have all of these stigmata? And unfortunately, we had to say, this is an autosomal dominant disorder, so the child has a 50% chance of inheriting it, that we can't tell her. There's no way that we can talk about what the expression or the phenotype will be. These kids can be mild like her, but they can have large plexiform neurofibromas, they can have seizures, they can have eye tumors, 40% have learning disabilities. And she said, okay, I'll get pregnant. And this is her child, who unfortunately had a very, very large tumor, large plexiform neurofibroma here, had the typical pseudofracture that kids with neurofibromatosis have, and was much more affected like the mom would be. And we can assure you, because of his effects, that he will certainly be much more incapacitated than she was. So variable expressivity goes with all the new genetic things that we've developed, but alternatively, it's not something new, and genetic counselors are pretty used to dealing with it. Hopefully, with time, we will have better genetic ability to look at the other moderating genes that are associated and be better. But right now, that's really all that we can do. The other thing that I want to talk about in the last 10 minutes is the second thing that's happened in our field. And I talked to you about the age of the mom, but we have much, much, much better screening tests now that we can look for things like trisomy 21, 18, and 13. And that's because of an observation in 1997 that demonstrated that floating in the plasma of every pregnant woman is cell-free DNA. DNA that's not in a cell, and it's small fragments of DNA, about 130 to 140 base pairs. Some of those fragments, about 90% of those, come from the mom, but about 10% of those fragments come from the fetus. So the question was, is there any way that we can do genetic testing on the fetus by drawing blood from the mom and evaluating these fetal fragments of cell-free DNA? Where do they come from? It's a misnomer to say they're fetal DNA. They actually come from the placenta, because the placenta is constantly undergoing programmed cell death or apoptosis. So it really is cell-free placental DNA. So the answer is yes, and we can do it well. And just give me a second with this cartoon. Normally, in a normal euploid pregnancy, and just in yellow are chromosome 21s, and in purple are chromosome 1s. So the ratio of the DNA, or the number of chromosomes in a normal euploid pregnancy, of 21 to 1, and I just chose 1 arbitrarily, should be 1 to 1. If it's a trisomy 21 pregnancy, there would be 3 number 21 chromosomes and 2 of our control chromosomes. So the ratio of the 21 to any other pair of chromosomes would be 3 to 2. Those of you that work in a lab would know how easy it would be to identify this using qPCR or a number of different techniques, because the 3 to 2 ratio of a chromosome to a control is pretty straightforward. However, you have to remember that this is diluted in 90% maternal DNA, and the mother's got 2 21s and she's got 2 of this control chromosomes. So in order to identify that 10% of slightly extra DNA from chromosome 21 and that 10% of fetal DNA, we would have to be able to identify a ratio of 1.05 to 1. Well, what do you do when you have to identify a very, very small difference? You just keep repeating the experiment, or you just keep counting. And so what has happened with next-gen sequencing, we do mass parallel sequencing. So again, this is just an illustration. Here we have the DNA in the mother. Most of it in black is from the mother. A small portion of it is from the fetus. The sequencer then counts these small fragments. I said the fragments are about 140 base pairs, but it only counts about 35 of the base pairs. And then the computer says, okay, this fragment came from chromosome 1, this fragment came from chromosome 2, chromosome 3, chromosome 21. And then you do this somewhere around 20 million times. And basically, you then count how many pieces of DNA were from 21 and how many were from that control, and you just look at the ratio, so that we can now non-invasively identify pregnancies that have slightly too much DNA from any chromosome. And here's just some examples of some of those experiments. This is the ratio of 1.05 to 1. You can see these are the Down syndrome pregnant. That's the ratio of DNA from 21 to 1. You can see that how easily they are separated. Now, on some occasions, there are some in that gray zone, but this technology has really become dramatically efficient at doing it. And for those of you who work in bioinformatics and think about this all the time, when I say the ratio of 21 to any control, we do have to take into consideration the total amount of DNA, because 21 is a smaller chromosome, so there's a lot of mathematical manipulation to do that. We also have to take into consideration the DG content and a number of things, but it's really not a gigantic scientific experiment. It's really been a gigantic ability to build really good algorithms that can look at these very, very subtle differences in DNA. How efficient is it? This is an old slide, but it could be today. This is their detection rate for trisomy 21, 99.9%. Almost all Down syndrome pregnancies can now be identified by a blood test taken on the mom. 18s are now about 96 to 97%, and 13s are about 95%. Remember I showed you in the beginning with the age. Initially, we got 30% of trisomy 21 pregnancies for 5% screen positive, or today, for 15% screen positives, we got about 50%. Look at the false positive rates. The false positive rates, these now have specificities of 99.7%. 7 per 10,000 false positive rates compared to what it used to be, somewhere around 5 or so percent. So this technology has changed things dramatically. Sure.
At what age is the fetus?
Thank you. First trimester. You can do it as early as 9 weeks of gestation, and it doesn't matter if you do it at 9 or 19. The amount of cell-free DNA stays about the same, and as I said, it's about somewhere between 4 and 10% of the total cell-free DNA in the mom's circulation comes from the fetus. So the gestational age is not that important. So you can see that if one wants to just look for whole chromosome aneuploidies, and you don't want to look at some of the more subtle things, and many, many patients don't want that. They really just want to look for the most common things. This can now be done quite well by just drawing blood from the mom in the first trimester. So, this is what patients face nowadays. The two options, we can have improved screening by drawing blood, and in that particular case, they're limited to 13, 18, 21 in the sex chromosome abnormalities. They could have an amniocentesis or a CVS and get all the chromosome abnormalities, because cell-free misses about 20 to 25% of the rarer chromosome abnormalities. And they can identify the copy number variants. And that's all separated by the risk of an amnio or CVS, which is about a 1 in 500 chance of losing a pregnancy. It's really pretty uncommon to have a loss. So this really is the dilemma, or not really the dilemma, I would say this is the opportunity that patients can decide exactly how much and what information they want to have. Last, in the next 5 minutes, just want to talk about where we're going. And where we're going, as I mentioned, we are already sequencing fetuses as a research project. But let me demonstrate how important this can be. Here is a case of a woman that delivered this child about 10 years ago, a decade ago. The child has severe microcephaly. You can just see how much space there is in the cranium that the brain is not filling. Severely cognitively impaired, and as a matter of fact, died at the age of 1.5 from pneumonia. And the parents said, until we can find out if this is going to happen again, we're not having any children. And they came to us 10 years later and said, everybody's told me there's no way you can promise this. So we said, well, maybe we could sequence this kid. How are you going to sequence? The kid's been dead for 8.5 years. And we said, would you have a hairbrush? Do you have any other things that you might have DNA? If you use hair, it has to have the bulbs on it, so it's not good. I said, do you have any remnants? They said, absolutely not. So we called the New York State Department of Health, and every kid that's born in this state has a heel stick done in screening for genetic diseases, and they put blotches of the kid's blood, and they store all of these in a freezer. So we called the State Department of Health, and we asked if they still had the blood spots from that kid. Indeed, they did. We got this, and they actually were able to extract the DNA and sequence it, and lo and behold, both parents, lo and behold, the kid was homozygous for an asparagine synthetase deficiency. Both parents were carriers. Asparagine synthesis deficiency couldn't be more similar to what their kid had. The MRI, the CT, the phenotype, etc. So now they're getting pregnant, although a little bit later in life, and they now know that we can make the diagnosis and they don't have to worry about it. The other point just to make, and we don't have time to go into it, for many families like this, we now can do PGD, pre-implantation genetic diagnosis, where you can do IVF, you can take a 3 or 4 day old embryo before you even put it into the mom. You can take 3 or 4 cells, you can amplify those cells, and you can do karyotyping, and in many cases, you can do sequencing, or you can do whatever you need to do, and then you only put back the unaffected eggs. Now, it entails IVF, it entails $30,000, but there are lots of people that getting a pregnancy, diagnosing something, and then terminating it is not acceptable, so we've even moved the ability to diagnose these things down to preconception. Last case is an ultrasound we saw a couple years ago, and these are the 2 feet, and if you count, there's way too many toes. I think there's 8 toes on this foot, there's like 7 toes here, there's a gigantic gap, and there's a big toe, or something that looks like a big toe on the right foot. And the differential diagnosis of polysyndactyly is listed here. There's a number of syndromes that are very, very severe with really both medical and cognitive impairment. And there also are some syndromes here that have nothing but limb abnormalities, and the kids would be cognitive totally normal. So in this particular case, the woman was faced with, oh my God, am I going to have a kid that's going to be so severely affected, but do I really want to terminate a case that could be an entirely normal kid? So we offered her sequencing, and we sequenced and found that there was a mutation in the sonic hedgehog gene, which is associated with triphalangeal thumb with polysyndactyly. It's really rare, but the important thing, it is only a limb defect. All this kid has are the limb abnormalities, and other than that, it would be perfectly normal. So with that information, which she wouldn't have had without sequencing the fetus, she continued the pregnancy. You can see this is the left foot. 1, 2, 3, 4, 5, 6. Yep, it's the left foot with 8. You can see this is what looked like the big toe. The kid also had polysyndactyly of the hands. But in this particular case, and again, I just make the point that having the genetic abnormality cuts in both directions. It gives us a lot of reassuring information about a lot of pregnancies, too. And then the last thing to realize is that everything I talk to you now that requires invasive testing will be done in the next 5 years non-invasively. There now are ways to identify microdeletions by just drawing blood from the mom, and there have been 2 papers in which they have done whole genome sequencing on blood drawn from the mother. It took them 6 months, it took a lot of time, but once you can do it once, you know that that'll come. But think about it. The questions that this is going to raise. What should we be looking for? Should we look for everything and let the parents decide? How many variants of unknown significance? What all of this? But it's going to come, and it's going to really be an important time for all of us to help make decisions about how we're going to handle all this information. But this is how I see the future. This is a CVS on a woman, totally normal karyotype, but she had an array that showed there was a deletion on the long arm of chromosome 17. This was done at 10 weeks of pregnancy. The ultrasound was perfectly normal, and the woman said, "You are crazy. There's nothing wrong with my baby. Look at that ultrasound. It couldn't be cuter." But now we had the genotype, and we said, we know that this genotype, we know the gene it's associated with, we know it's associated with renal cysts, and it's associated with maturity onset diabetes, and a certain percent of patients that has other complications. We said, just come back and see us in 4 weeks. She came back in 4 weeks of pregnant, 4 weeks later. Here's the kid's abdomen. Here's one gigantic kidney. Here's the other. You can't usually see kidneys like this. They're really, really bright because of all the cysts they have in them. But what this illustrates is it used to be that we would have a phenotype. A patient would walk in the office. A fetus would undergo ultrasound. Once we saw the phenotype, then we rub our head and we say, what genetic test should we get in order to find out what the genotype causing that phenotype is? No longer. Now we have the genotype way before we have the phenotype, and then we can just take a step back, like in this case, and just look at the phenotype develop. And most importantly, because we know what's coming, we can make plans to alter that. It's really changing the way that we're thinking about medicine, and certainly in fetal care, it's allowing us to really prospectively look for problems. So hopefully I pointed out that we do personalized medicine for fetuses, and that it really does make a difference. So